Speakers have movies on their presentations that may not play on this drive. Everyone else is okay? The flash drives will work. Everybody's okay? Think so? Okay. All right, well, I'm really delighted that I get a few extra minutes because I'm one of those people that's going to be a problem. So. All right, so my talk is going to be an introduction to RSD and CRPS. That'll be followed by Dr. Brioschi's talk, by the way, and then I'll have another talk in the morning session. I put this slide up to let all of you know that just about everything I'm going to say is available on my website. So in the future, if you want to look something up, you can go on to piedmontpmr.com, and you'll be able to find just about anything you want there. And if there is an encrypted form because of HIPAA, there's an encrypted place that you can email me. You can certainly ask any questions, and I'm pretty good at responding. All right, well, I thought the first thing that we do is talk about today not only what is RSD, but what RSD isn't. There's a lot of confusion, as Dr. Argawal has talked about today, and hopefully at the end of this meeting, you'll have a really good handle on that. So just normal peripheral nerve anatomy. Most of us are aware that we have dermatomes, and that they come out of the spinal cord, and these are sensory nerves, and they follow explicit tracks on the skin. Not as many people are aware that we have also myotomes, and in the case of a myotome, it's just simply where that same nerve root ends on groups of muscle fibers. So for somebody like a physiatrist who's doing electrodiagnostic studies, that's one of the ways we differentiate what particular nerve root might be involved when we're checking our myotomes. But that doesn't work for the sympathetic nervous system. In the case of the sympathetic nervous system, it doesn't originate from the spinal cord, but instead from something we call sympathetic ganglia. These are like freeway interchanges. They don't require the normal street lights. They operate independently all by themselves. They do have feedback loops that go through the spinal cord, but independent of the spinal cord, they enter into the limb, and they end on the arterioles. So they may travel with the course of a peripheral nerve, but they end on the tiny blood vessels that go on the skin. And these ganglia, in anatomy, we call them things like the stellate ganglion, or we'll show you pictures later of the superior cervical sympathetic ganglion. There's also this phenopalatine ganglion. So whenever you see these little clusters of the sympathetic nerve, they're called ganglia outside of the nervous system and operate independently, and that's why they're part of the autonomic or automatic nervous system. Now, there's many expressions of sympathetic pain that all of you are aware of. You're just not necessarily aware of what you're looking at. So most of us have heard of myofascial pain. For example, here is a gluteus medius muscle. You have a trigger point, quote unquote. You press on that muscle, and the person says that they feel pain that goes all the way into their limb. And that particular map or distribution for this sympathetic pain or muscular pain happens to be tracking in what we might think of as an S1 nerve root. But it's not a sensory nerve, it's not a motor nerve, it's from the sympathetic system that's doing that. They'll say they feel tingling, they feel numb, you stick them with a pin and they go, ouch. So this is the person they go, okay, they say they're numb, I stick them with the pin, they go, ouch. Well, rather than just thinking that maybe this person's got some emotional issues, you might say, okay, they're nulliness. Instead of numb, it's null, and that's C fiber or sympathetically mediated. Likewise, certain neurosurgeons would be aware of this, but the dura itself is C fiber mediated, and these people present with these Shaw-like or big draping distributions of pain when the dura is the source of the pain. I'm very involved in regenerative medicine and into ligament, so I will tell you the way to differentiate when the ligament is involved. For example, you have C4-5, C5-6, and they'll get the same distribution or kind of pain that you might see with myofascial, but it always skips a joint. So if you're always saying to yourself, oh, I have leg pain that goes all the way down into my foot, you might say, well, do you feel it in your knee? And they'll say no. They're telling you that's not radicular. They're telling you that's sclerotomal or C fiber. By the way, I also like to stop the talk for just a moment. Has anyone in this room ever experienced sympathetic pain? Okay, we've got one or two. Has anyone in this room ever sprained their ankle? Okay, I'm going to ask Dr. Davis. Can you tell me what it felt like when you sprained your ankle?
Hot.
It's hot, burning, swollen pain. Okay? It's not a sensory nerve. It's not a motor nerve. All of you know what sympathetic pain feels like. It's just not dystrophy. It becomes dystrophy when that hot, swollen, burning pain becomes abnormal. All right, well, so there's something about sympathetic pain that just doesn't fit the typical injury model. Normally, we have some kind of tissue that gets injured. We have release of arachidonic acid, prostaglandins, bradykinins, and this causes inflammation of the nerve fiber. It goes up into the brain, and this is what we normally call our black box, or our box that fits in what we're trained in medical school. But there's something strange about the autonomic nervous system. When it gets involved, since the sympathetic system works independently, it creates its own independent and sometimes reverberating feedback loop. And when that happens, the brain and the spinal cord start reacting to it because the sympathetic system works through neurotransmitters, things like epinephrine and norepinephrine, and start affecting some of our other hormones, our thyroid, our adrenals. And we get extrusion of substance P and peptides and other hormones. Well, as a result of that, the immune system reacts, and we get an increase of platelets in the area. And we get increase of mast cells and inflammatory cells in the area. That causes a release of histamines and increased serotonin. And as a result of that, the kidney reacts and spits out increased angiotensin, trying to control this wound healing and inflammatory cascade. Well, your blood vessels react to all of this. Not only do they see a sympathetic response in order to constrict, now they have humoral, kidney, and organ system responses trying to react to the local injury site. At the same time, many of the infective agents that are harbored in our body that are naturally there, things like mycoplasma, may become exposed. And for all we know, one of the reasons this particular person got dystrophy is because at the time that ligament was injured, mycoplasma or some other cascade infected the nerve or affected the nerve so that it can no longer maintain its normal physiology. So one of the approaches that I like to take when I'm treating a dystrophy patient is ask, why did this person get dystrophy? What can we do to treat the source, not just the symptom? No matter how you look at it, dystrophy patients don't fit the normal black box. We do know that normally with pain, we have a stimulus intensity, and that as we raise that intensity, at some point they start to feel the pain, and at some point they complain of pain. But in the case of RSD, that entire curve is shifted to the left. So what used to be just a normal sensory response is now a hyperalgesic response or excessively painful response, and what used to be a non-painful response is now called allodynia and is a painful response. Pain resulting from non-painful stimulus. All right, well, what's the history that a patient may give you that has RSD or CRPS? Almost always, if you dig hard enough, sometimes you got to dig a little bit, but it's almost universal that all patients are going to have some kind of underlying event, some kind of injury. And it can be a minor injury. It can be something as simple as I bumped my knee on a corner of a table to a major crush event or major trauma. And they'll describe their pain as burning, gnawing, cold, sensitive, or allodynic. It may or may not directly involve a tissue or a nerve. Many people think you have to have nerve involvement to have dystrophy. It's simply not the case. We like to look at what are the predisposing factors. Since we're going to be reducing total load, the total number of things that make this person's dystrophy bad, what are those factors that are making them more likely to have dystrophy or that are making their dystrophy harder to heal? So the literature is pretty clear that if you've had a stroke, such as in shoulder-hand syndrome, or a heart attack, or a fracture or crush injury, that those are things that predispose people to getting RSD. Still not predictable which one will get it, but those are ones that we know are more likely to get it. I also ask my patients, are they cold hand, cold feet? Are they normally just with their sympathetic systems on overdrive anyways? Do they have an endocrine disorder? Do they have diabetes? Do they have hypothyroidism? Do they have hormonal reasons that make their system cold anyways? Do they have clotting disorders? And I don't just mean do they have clotting disorders where they need to be on heparin for life. 20% of all Americans have some kind of minor abnormalities in their clotting system. Something affecting protein C, some of the antithrombins, just something that makes them clot just a little bit more. Maybe there's like tiny little microemboli that now that this injury's occurred, came out, affected the C fiber, and caused this sympathetic nerve to not want to heal itself. Are they taking birth control pills? Are they a smoker? And then do they have perpetrating factors? Do they have certain ongoing problems that won't let it heal? Not that predispose them, but isn't allowing them to get better. Are they form frust lupus? Do they have lupus? Do they carry low-level ANAs? Do they have low levels of rheumatoid? Do they have peripheral arterial disease or cardiovascular disease? How about venous reflux or thrombosis? The more I've treated dystrophy, the longer I treat it, the more I think that it's essentially a vascular disease and may be neurologically driven at the onset, but the way to treat this is to address the vascular system. And then, of course, we've already mentioned a little bit about chronic infection and mycoplasma. It's a theme that we'll talk about more as I go along. A patient comes to you with a diagnosis of RSD, that's how they come to me, or you're wondering if they have RSD. I would strongly suggest the first thing you do is make sure that they don't have something else. You really want them to have anything else that's treatable. And a lot of these other treatable conditions really can present as RSD. Everything that you see on this list, somebody at some point has been referred to me as having RSD, and rather if I treated one of these other issues, whether it be insufficiency, stress fractures, nutritional disorders, ligamentous strain, thoracic outlet, I was able to reverse or cure their quote-unquote RSD by treating a different underlying condition. What might we see on the physical exam? In some cases, you see nothing. Okay, now we have classic stages of RSD, and we'll go through this, but I call this RSD stage 0.5. We just tend to call them all RSD because it's just easier, but this is really more like a sympathetic pain syndrome. They look normal, they don't have any vasomotor changes, they don't have any pseudomotor changes, but they're weather sensitive. And they'll tell you, yes, these tornadoes are going to be bad. I don't know about the other physicians in this room, but I suspect many of the patients in your offices over the last week have had a hard time saying my pain was worse over the last week. You're shaking your head, yes. You might say, I bet you that person had a hard time with all these huge tornadoes that just hit. They're telescoping to you, they have weather-sensitive pain. And by the way, we didn't get them in Greenville, okay? So it's not the weather outside that does it, it's the barometric change in the fronts. And depending on how sensitive that person is to those changes is going to be how sensitive they are to communicating their sympathetic response. Classical RSD is stage 1. You get vasomotor and pseudomotor changes, you get skin temperature changes, and you get sweating changes. You don't expect it to be a cold and a sweaty hand. You expect a hot, sweaty hand. In dystrophy, it will be a cold and sweaty hand. That's why we call it dystrophic. When you go into stage 2, we have classically defined edema, contracture. Not contraction, but contracture. There's a lack of full motion. In stage 3, you get bone loss, or pseudic atrophy, and muscle atrophy. In the literature, if you read the literature, it talks about this progression of stage 1, 2, and 3. Most doctors that are involved in dystrophy will tell you that that classic projection or progression doesn't necessarily exist. You can get somebody that goes right into stage 3, or it can take time, or they may not ever make it into stage 3. We've also worked on a diagnosis called RSD with dystonic features, and it's my video that's not playing. Let's see if I can get that to kick in. This is a case of a woman who hands does this, okay? And many patients with RSD have what we call dystonia, or abnormal tone. Sympathetic system is not supposed to affect the motor system, but it does. And if you read the literature, especially people like myself in our offices that see a lot of dystrophy, you will find there are references to RSD with dystonic features. We can talk about whether this is hepatic transmission, whether there is brainstem overlap, or where this comes from. But in these patients, you can treat the dystrophy all day long. The only way you're going to fix them is to first stop the motor disorder, usually with botulinum. Then you follow with your sympathetic blocks and treat the source. I'm going to blame this for my video not working. Okay. All right, so you know, I'm pretty good about telling you what's reality versus what this is Dr. Schwartz, or this is kind of what other people say. So again, the reality is these stage 1 through 3. We call it stage 0.5 in our office. Now we've talked to you about dystrophy with a motor form of dystrophy. And we've also been one of the first offices to publish RSD with spread. There's people that say, no, you have RSD with your hand, it can't spread, and we're here to tell you that that's simply not true. Dystrophy does spread, and it can spread. It can spread to different body parts and different limbs. That doesn't mean, by the way, that if somebody comes in and says, I've got RSD in my hand and now my other hand hurts, that they have dystrophy. They'll tell you that they do. The patient will believe that they do. And in 90% of the cases, they don't. They have another disorder. But that disorder needs to be frequently worked up and quickly worked up because you don't want it to spread. And there are cases where spread does occur. I'm also a very big advocate of somatovisceral pain. In the case of somatovisceral pain, all of us seem to understand that somebody can get a heart attack and that can affect their chest wall and that can affect their left arm. But what is it about us that makes us think that it's a one-way street? Why couldn't you have and why don't you have an autonomic dystrophy or a sympathetic dystrophy of your left arm that may in fact cause arrhythmias or autonomic dysfunction in the heart? And we've published several articles on patients in particular with eye, who Dr. Heitman will spend his whole talk on, and heart in particular, some of the dental organ systems, and many of the GI symptoms where you get a spread, somatovisceral spread of the autonomic nervous system. And the slide simply demonstrates the clear connections between the somatic and visceral systems. All right, so we've kind of gone over what normal is. We've gone over what is RSD. We've gone over a little bit of an approach of using differential diagnosis. What do you do when you're starting the workup? As Dr. Argawal has said, there's no universally accepted do this, do that, and you'll have the workup, you'll have the diagnosis. By the end of the day, you're going to have a very good feeling for that. The first thing I do is I start out with lab. I'm looking for rheumatic conditions, I'm looking for vascular disease, clotting disorders, I'm looking for hormonal diseases, infectious problems. I want to see what their immune system looks like, what their nutritional status is. It's amazing, you know, if somebody's really got a vasoconstrictive disease, even if it's just RSD, better make sure they have enough magnesium, because without it, you're never going to get them to vasodilate. Do they have heavy metals? Do they have mercury? What do I have to do to allow this nervous system or this entire person heal? And I look for comorbid disease. The comorbid disease may be the actual generator of the dystrophy, or it may be the perpetrator of the dystrophy. And in fact, the comorbid disease may be more painful than RSD itself. So many people see RSD and they go, oh my God, this person's going to lose their limb. They're going to get pseudoatrophy. This is terrible. Well, guess what? They can have relationship problems to their disease where their behavior is worse than the disease, just like any other problem. When you start understanding the problem, you can start accepting, no, this is behavior, this is disease. Or maybe in this case, this person didn't have dystrophy at all. She had lymphedema, and that's what needed to be treated. So now I've talked to you a little bit about what RSD is. I want to go over several things about what RSD isn't, with the idea of hoping you understand these so that when you see them, you'll go, wait, no, this one is dystrophy, or no, this one isn't, or what my approach can be. This patient was literally referred to me with RSD, and they had a strained ankle, literally. She had sprained her ankle. She was told to stay off it, to get on crutches. She became allodynic. She became frightened to put weight bearing on. She had vasomotor instability. She had clear skin color changes. She was allodynic, hyperpathic, but she had no trophic skin or nail changes. And when we did thermographic imaging, there was no pseudomotor instability, no vasomotor instability, pseudomotor changes. We treated the ankle, and she got better. Because of my journey in RSD, I became more and more interested in vascular medicine, and over the course of time, I've been fortunate and blessed to become a fellow in vascular medicine. As a result of that training and going through all the vascular meetings, it became clear to me that most pain physicians don't know anything about medicine, and most medicine physicians don't know anything about pain. And if you go to a 1-week-long course for board review on vascular medicine, at the very end of it, they'll give a 15-minute session about